So, who wants to start with a question to this esteemed panel? Oh, Barbara, you look like you're chomping at the bit to say something. No!
Hi, this is for Barbara and Caitlin. Really impressed with your reduction in loss to follow-ups. Could you just elaborate a little bit more in regards to how the patients accessed NRT if you were providing the behavioural support and the pharmacy obviously wasn't?
Yes, we can do, yeah. Oh, yeah. So they would be issued with 2 weeks NRT when they're discharged from the ward, and then we use a it's a handwritten kind of voucher system. So we post that to the patient's home address, and then they can go and collect that from any pharmacy pretty much in Gateshead. We do have another method. It isn't quite as reliable. That relies on our in-house outpatient pharmacy, who could dispense the NRT and then deliver it for people who have, some kind of something that would prevent them from being able to collect it. And that works. It works fine. Nobody is ever left without any. Sometimes it's a bit of an issue, which is a different subject, but that's making sure that everybody goes home with the discharge NRT, which I think everybody gets. But that's. But yeah, usually for the most part, it all works fine. We are working towards farm outcomes longer term. We use that for the maternity service, and that works really well. But there's some kind of obviously there's some barriers and things like that, and we can do that more wider across Gateshead. But we believe that system would probably work a lot better. Just reducing kind of documentation and all that kind of thing. We're always acutely aware of how much work we're putting onto our TDAs, and we tell them so many times every day that we wouldn't have a service without them. But because of the the enhanced discharge pathway, the work in the maternity service, the work in the inpatients and everywhere else, and we only scratch the surface in our hospital, because in all of our outpatient clinics we see people every day who really need the support that I know and what we know as a team we can deliver this, but it takes time. But there's so many patients who desperately need our support, we can't reach them, and we don't want to set them up to kind of feel we don't want to take them on, but we still do take them on. I kind of wait to speak to somebody later, Alfie off yesterday, it's just because they mean so much to us and we're emotionally invested in to get people to be smoke free. It means so much to all of us. Sorry, that was a bit of a long one. Sorry.
Thank you. More questions?
Oh, that's really loud. I was just going to add that it's like the NRT is funded by the council, so the TDTS are commissioned by Gateshead Council to provide that 12-week support. So the processes that we use are really lucky that we can tap into the council's existing processes that the kind of universal providers utilise already. So NRT funded with the vouchers.
So that's a good example of a true place-based system working, and I guess it's just useful, isn't it, in terms of the importance it's NHS and LA's together really, and going back to that figure of the person with tobacco dependency to really inform the planning. Any more questions from the floor? I'm sure there are. Or you're all blown away by the fantastic practice. Ooh, Ruth, yes.
Obviously really impressed with everybody's quality improvement work, and I've taken loads of notes so that we can all sort of draw from that. Really keen to hear what's the next things on your horizon, what's the next project you're going for with quality improvement, all of you. Thank you.
Is that me then? So yeah, I've obviously put on there the current quality improvement project, and it is about, it's not easy. It's more within your control to do what you can as a service at your level of input within the care. But I think what everyone else is agreeing is it's about embedding the culture across and getting a collective responsibility. So that for me is a big part of quality improvement. It's changing the staff culture around the importance of initiating an RT. But coming from a clinical background, it's it's about recognising it from their point of view as well, and seeing from a staff's perspective, it's like getting through the shift, having enough staff on shift, it's the pressures. So, and in their eyes, it would be, what's that adding on to my role? So it's about making your messages consistent, simple, really brief, and any step in the process where you can make it easier to implement, do that, like your automatic referrals. Simplifying the choice of nicotine replacement therapy that the ward staff might offer, and expanding on that when you get in there as a service. So it's just, you can't fix it all overnight, can you? It's just looking at every step in the process. So that's going to be a big one that's going to take some time for us.
Thank you, North Tees.
So where do you start? There's so much, isn't there? Obviously, I mentioned earlier about outpatients. That's something that I'm really quite... I really think that we should be doing, totally missing the trick with outpatients. It's a captive audience and they're sat waiting for sometimes a long time for an appointment. But for me, it's sort of identifying for inpatients on admission, trying to get everybody to identify them as a smoker, because obviously we need to identify what the smoking status is for national submission. We only have about 60% of our patients identified at the minute, which is great compared to what it was, but it's still not good enough. So that's sort of the next thing that I really want to work on, is actually getting out to the wards again and reinforcing again. Just tick the flag on chemists. It's a 2-second job, and that tells us, and we get a report every day of the smokers. So it's not difficult, but it's just a lot of people are there, but there's a lot of people still. You still have some challenges in some wards.
Gateshead's next priority.
2, I'll say 2. I think I could say loads, but yeah. So yeah, smoking status, and on admission we do manage to get up to what we need to be, close to 100%, but that's because the TDAs do half of that. So we've got just 56% of clinical staff do smoking status on admission, and the TDAs, we do the rest, which is so much better than it was in the beginning, because it was basically 0. So we've still got a long way to go, but we've certainly came some distance already. But the other thing that massively leaves open is weekend working, because we're not there then, but the tobacco dependent individuals are there then, and it's not fair. Should you get admitted into our hospital on a Saturday, you'll not see us whatsoever. That's not fair, that's not equal, and that's not how we want to run our service. So and we'll hope both kind of things hand in hand will improve the smoking status on admission, I think, along with kind of upskilling the teams, just being there all of the time. But you know what it's like, it's really hard. But I think it's just keep going back them and explaining to them, why do we do it? Why do we want them to do smoking status on admissions, and not just give them another task to do at 3 o'clock in the morning, because we all know with a clinical background, everybody knows how that looks. It's about explaining them what to do, and just kind of getting them again a little bit, even if you've only got a few minutes with them, to get them emotionally invested so that they'll actually see the point of doing it. And as you say, we have a BI report, which is great. All I have to do is, so long as they click that box, we'll know exactly where that smoker is. Yeah, but yeah, yes.
Just something that Barbara said there about like sort of getting the staff engaged. I do the care certificate course, so it's like I go on long speech, all the healthcare assistants, and actually one of their characters telling them what nicotine withdrawal looks like. This is your patient. It was buzz, buzz, buzz. I want to go for a fag. Actually, they're not being awkward. They are suffering, and you can see that light bulb moment in someone. They go, oh, that's why they're doing it. And that actually, if you get into the sort of like the frontline staff and tell them this is nicotine withdrawal, our patients are suffering, and if we can help them, it's going to make your life easier as well, and actually it's going to make their hospital stay and their outcomes a lot better. So that's sort of been one of the carrots that we use.
And I suppose just one of the things I wanted to add as well, in terms of, things that are happening in terms of quality improvement across the system, is we are looking to increase the number of options that tobacco dependency treatment services have in terms of a stop smoking aid. So, in parallel, what we've been doing is working with colleagues in pharmacy across the ICB to add cytosine and varenicline onto the formulary in the North East, which would mean it would be available in any setting, whether that be in secondary care, whether that be in primary care. And I think, it's about giving more tools, recognising that these are evidence-based treatments. They're recommended. I know they're included in the care bundle and the training. So it's about making sure that we've got access to treatment that's suitable and flexible. So that piece of work's going through at the moment. It'll also include PGDs within the community so that local authority stop smoking services can continue those medications when they're discharged.
Brilliant. Thank you so much. Anything else from the floor? Rachel? Yep. And then I think we shall sum up an amazing morning.
Thank you. I just wanted to ask the panel, if there was one thing you could advise trusts who are thinking, gosh, where do we start? How do we go about having those conversations with people in the trust or with our LA colleagues or doing quality improvement? A tip or just something, word of advice from the panel?
From my point of view, I think it is about being collaborative, whether that's being collaborative with partners externally, local authorities, but actually also being collaborative within the trust, working with quality improvement teams, working with the assets that you have to hand. So I know, for example, quite often junior doctors are a really key asset, and they're so passionate and you can get them involved, and for me it's that collaboration.
I don't want to steal Barbara's thunder, but I think find your people. So like people who believe it, want to do it, know how we do it and why it's so important. Like we are so lucky to have Ruth and Barbara and the team, Gemma, Karina at the local authority. But also like our data person, Andy, is phenomenal, and the data we presented earlier, we might have captured all of that, but if we didn't know how to put it into the system, pull it out of the system, submit it, we wouldn't be able to. So I think find your people. It's probably quite a small group to start with, but build on that and find people who are passionate and want to do this and want to make a difference.
Yeah, absolutely read my mind, Kit, and that's exactly what I would say as well. And our TDAs, they're the people who are doing the work all day, every day. They're on the wards all morning, and then they're doing all of the computer work on the afternoon, and they so care about the patients on such a level. Like they don't get inappropriately upset. I don't mean that, because it's but they feel for the patients, and that's so. There's nothing like that, and it's palpable, And so when they're following them up, when they go home, they already know about them. They know why this, knows so much about them, and then when they're following them up, it makes it so much easier for them. So for me, it's the people, the wider team, and particularly the people who are doing the doing and keeping them well, keeping them happy, because it's such an emotionally draining job. We do have a lot of our service users who pass away, who we have poor outcomes, and because of the patients that we are dealing with at times. So, and to look after our little team is what I would say.
Yeah, just what Barbara said, it's about listening to your team, learning the challenges and the themes, and putting the tools into place that give them the ability to do the jobs to the best that they can. So it's your direct supply of nicotine replacement therapy really helps the advisors. Being able to provide vapes for inpatients, that really helps the advisors. So it's looking at how you can take all that back and implement it at the trust through guidelines, through local instructions, through anything that's kind of going to enable that access to care. Also, it's about finding your allies, finding your key stakeholders, and learning from them in a forum to just escalate things up through the trust. So it's really good that we've got a prevention group at our trust, and it's got really good, passionate key members. That obviously public health that's here, and the head of our care group is it's massive on the agenda, prevention. So it's finding a way to bring all the programs together and get that input really. And obviously your clinical lead and your exec support really helps as well.
Thank you.
Probably just a reflection of what everybody else has said, but having that those people, the key people you can go to, your management leads, getting in on the right meetings to speak to people. I went to the clinical matrons meetings a couple of weeks ago, and that was like the one I was most nervous about, because they're like sort of my peers from nursing days, and they were brilliant. They were so engaged, and you don't realise how much support's out there till you actually go and look for it. So it's having those key people, and then knowing who you can go to when there's a particular issue on a ward. and having like really good engagement from your management team.
I'm going to echo what was said. We wrote a paper, it was called Good to Great, and it was looking at inpatient tobacco dependence treatment in Canada, and what stood out was the great were the people who had, the organizations that had strong leadership in the form of champions. Clinical medical, nursing, and administrative. So I think where do you start? You start with finding those people, and it echoes what you've already said, and then matching them with the quality improvement individuals, though, which really bring it together.
Brilliant. Thank you so much. What amazing sharing and learning. And if there's one thing I'm going to reflect on about this morning is it's find your people. Well, it's so clear the people are in the room today, aren't they? You are the catalyst for change, and I have learned so much and been inspired by how hard you're grafting, how hard you're working, but how passionate I think people are, because you know the difference that you're making, whether it's that synergy between local to regional to national. So I did just want to kind of, without further ado, because I know people can smell lunch at the back of the room, just a huge thanks to everybody from this morning for making it such a great sharing event, and particularly for you and for coming. And I think he's been exposed, definitely. There was no doubt he gets it, but for him to have heard what you're up to, I think is really important. To maintain that commitment from our ICS. So we are going to now break for lunch. I'm going to suggest, I'm looking at the scary boss here down the front, that we come back at 2:00, Rachel. I'm joking, she's not scary at all, she's phenomenal. But I'm going to suggest that we take till lunch, but I do want people to come back promptly. And just to explain this afternoon, there's going to be 2 sets of workshops. So at 2:00, you're going to be in 3 different places. So if you're not sure which workshop you signed up to, could you please go back out to the registration desk where it lists what your workshops are. So coming back to this room, this is the Granger room. Okay, so ignore me. So at 2:00, Sophia is going to be running workshop 1 on the NCSCT treatment bundle. That is in the Granger room, which is upstairs. Perfect. Workshop 2 is our wonderful team from Northumbria in this room. And workshop 3 is Joanna and Jojo looking at transfer of care and discharge pathways out of hospital in the grey room, which is upstairs. Woo! Okay, brilliant. Now those workshops are going to run for half an hour. Yes, okay. And then you'll have a quick workshop. So know where you're going for workshop 1 and then workshop 2, so that we can do a seamless transition over. So thank you so much. So we'll be starting these prompt at 2:00 on the dot. Thank you.